Hi, I am Misty Guantonio. This is an assignment I am currently completing for North Central University's MFT 6102 course on psychopathology, diagnosis, and systemic treatment. This assignment specifically addresses week 6 and
Growing up in the
providing a
mid-1900s,
diagnosis.
Sylvia lived a life with a very promising academic future. As a published and award-winning poet and artist, Sylvia had many attributes that would accelerate her potential as a writer. Though this proved true for Sylvia, it was not without struggle. With Sylvia being the identified patient, I will apply the diagnostic criteria determined by the 5th edition of the Diagnostic and Statistic Manual of Mental Disorders to appropriately diagnose Sylvia with major depressive disorder. As I go over each section of the criteria, I will provide evidence of the symptoms as they present. Significant qualifiers in the diagnosis of major depressive disorder is that 5 or more of the criteria listed in Section A must have presented a change in the client's previous functioning for more than a 2-week period and are not related to a medical condition. Of the 5 symptoms, one must either be a persistent depressed mood or loss of interest in normally pleasurable activities. Persistent in this case means experienced for most of the day. Sylvia acknowledged her life began to feel hollow just after her father's death when she was 8. According to Wikipedia, her serious battle with depression began in her early 20s, and losing interest in the pleasures of writing was evident when she found herself dispassionate, even though she was honored with an esteemed position at Mademoiselle magazine. In the movie, the loss of interest often paralleled the roller coaster of Sylvia and Ted's marital difficulties. Adding to the loss of interest is trouble concentrating or making decisions. This was obvious just after Sylvia married. Sylvia was finding it difficult to write, though she quickly brushed it off by rationalizing for learning her new duties as a wife by baking. Psychomotor agitation was apparent in Sylvia, with excessive hand-wringing when she found it difficult to concentrate. Later, when she was trying to reconcile with Ted, the symptoms represented. Because of her lack of productivity in terms of poetry, Sylvia's sense of worthlessness weighed her down. She made this known to her friends Ashley and David when they were visiting, when she referred to Ted as the real poet of the family. Recurrent thoughts of death began early in life for Sylvia. She began self-harming in college and spoke of her suicide attempt with Ted prior to their marriage. However, in a conversation with Sylvia's mother, she made it a very serious concern for Ted when she expressed how real the potential for death was for Sylvia. Though the movie did not go into details, Wikipedia documents multiple attempts of suicide before Sylvia's actual suicide in 1953. Other symptoms that I would be sure to inquire about in an interview setting would be if Sylvia experienced significant changes in sleeping patterns, fatigue, and finally, if she had any changes in appetite or significant changes in weight. In reflection, the entire movie captured the variety of ways Sylvia struggled to function. Socially, Sylvia had difficulty functioning within her marriage, and she developed few close relationships outside of her family. With her husband, Sylvia was insecure when it came to other women, as well as her husband's work, both of which contributed to jealousy and feelings of worthlessness. During one depressive state, Sylvia was not able to function at a normal level during a friend's stay. Sylvia's productivity in writing also waxed and waned with her depressive episodes. Outside of depression, Sylvia was able to produce recognized works such as The Colossus in 1960 and Ariel in 1962. Other than periodic alcohol intake, substance use and medical conditions were not a presenting concern for Sylvia. At this point in the diagnostic criteria, the DSM refers to sections A through C as a major depressive episode. As long as symptoms are present, the client is experiencing such an episode. However, other criteria must still be ruled out. Because Sylvia does not exhibit any symptoms indicative of psychotic disorders such as schizoaffective disorder, schizophrenia, schizophreniform disorder, delusional disorder, and other psychotic disorders, Section D can be ruled out. Sylvia also has no presence of manic or hypomanic episodes for the related diagnostic criteria, so Section E can also be ruled out. Sylvia's first major depressive episode was not a result from a loss or grief, and those, especially grief, must carefully be considered before diagnosing major depressive disorder. After reviewing the diagnostic criteria, it's evident to me the presenting symptoms are indicative of major depressive disorder. Next, I will discuss treatment options for major depressive disorder. Treatment options are broken down into three categories consisting of psychopharmacological, which is synonymous with pharmacotherapy, psychological or psychotherapy, and biomedical. For each of these categories, I will explore the effectiveness and drawbacks each treatment option presents. First, psychopharmacological treatments, which is most commonly antidepressants. According to Michael Yapko, antidepressants fall into a variety of categories based on how they work within the neurochemistry of the brain. There are multiple classifications of antidepressants available, making a variety of treatments accessible for patients with varying needs, and medication is the most popular form of treatment because it reduces symptoms of depression, allowing the patient to assume regular functioning. Though pharmacology and neuroscience have made many advances, there are still drawbacks that include more than monetary costs. Side effects can be extensive and include sexual dysfunction, agitation, insomnia, and more. In addition, there's drug interactions such as antagonism and synergism. There's potential misuse, such as forgetting medications, overusing them, and abuse that are potential risk factors. Other concerns include drug efficacy and relapse, which according to Kukin et al. Is a particular concern in patients who are not in compliance with medication directives. Though medication is not within the scope of licensure as a marriage and family therapist, it is still critical to have more than layman knowledge of both the risks and benefits associated with the implications of pharmacotherapy, as often the opportunity to provide psychoeducation in a therapeutic setting is available. In cases where patients are seeking both pharmacotherapy and psychotherapy, it may be necessary to refer the patient to a provider who has more knowledge of medication. The evidence of whether medication or psychotherapy is more effective in the treatment of depression seems to depend on what literature is being considered, but ultimately it comes down to what works for the client. However, according to Yapko, psychological treatment outperforms medication in 4 key areas. Psychological treatment has a lower dropout rate. It offers better social adjustments. It has a lower relapse rate than medication, and there is opportunity to teach prevention skills. In terms of teaching prevention skills, therapies that have proven more effective in the treatment of depression include both individual and systemic methods. Cognitive and behavioral strategies work best when symptoms are individually focused, and interpersonal and family approaches can be utilized, which I will explore on the next slide. The drawbacks of psychotherapy include the dropout and the risk of relapse, which is still lower than with medication, but the chance still does exist. Because depression is contagious, not via pathogens, but rather influential factors, family therapy can play a critical role in treating the entire system. As with individual treatment previously discussed, behavioral, cognitive, and interpersonal skills are addressed during family treatment. Yapko identified that family susceptibility or resistance to depression can last a lifetime depending on the prevention skills the family, not just the patient, actively practices. If put into action, behavioral prevention skills serve as protective factors that can help all family members prevent depression throughout their lifetime. Participating in family therapy provides a model for all members to increase appropriate social contact and enhances their relationship skills. An example would be two siblings learning how to use iMessages rather than name calling when their feelings get hurt. Finally, by involving the entire system in the therapeutic process, not only are all the members getting more education on being able to provide more support for the patient, they are also able to be more compassionate, hopefully strengthening the commitment and connection to the entire family unit. Potential drawbacks include relapse and the distance that could result if any member of the family chose not to participate in the therapeutic process. And the final treatment process includes biomedical treatment. Biological factors that play a role in depression include genetics and biochemistry. In treating depression, identifying whether or not a patient's neurochemical makeup is able to regulate mood is often a first step in the physical aspect of the exam. Antidepressants can often help regulate any neurochemical imbalances. Satognier's concern lies with clients who do not achieve remission after 4 treatments with antidepressants. These clients are likely to have treatment-resistant depression, as 30% of patients with major depressive disorder do. Satogne further explained that treatments need to involve both biological and social factors. Treatment-resistant only pertains to medications. Oftentimes, clients are able to find symptom relief through behavioral modifications pertaining to symptoms they can adjust simply via choice. Diet, sleep, and exercise are essential for a person who is not diagnosed with depression. Practicing them ritualistically can be the critical difference between hopeless and hopeful for a depressive. Adding light therapy to a daily routine can provide even more relief. Comadres et al. Found 30 to 45 minutes of daily bright light therapy, which is exposure to 10,000 lux of bright light, significantly improves core depressive symptoms, even when treated during spring and summer seasons. The drawbacks of patient self-care is accountability and reliability, and as with any form of treatment, relapse is always a risk. Even if accountability and reliability weren't an issue, some patients still need more intense treatment. Electroconvulsive therapy is an option. Research strongly indicates electroconvulsive therapy is effective. However, cognitive side effects are of concern. Electroconvulsive therapy does not negate relapse, and often patients still need to continue other forms of therapy. Though there may be a variety of treatment options available for depression, the most important factor is that the patient seeks treatment. That concludes my presentation on the diagnosis and treatment of major depressive disorder. Please refer to the reference section for any resources that you may need. Thank you for your time.